Morning, my name's Sarah. I work in Leicester. I do preconception counselling, antenatal screening and counselling, and newborn screening and counselling, so right the way through lifespan. Okay, so the brief was to share some of my experiences delivering the newborn sickle cell and thalassemia screening, including our local Leicestershire policy and pathway, some of the challenges that we face as haemoglobinopathy counsellors giving results, a few memorable experiences, lessons learned, and ideas for improving experiences. So there are two types of a newborn screening results. The first ones we receive from our regional screening laboratory in Sheffield, and these are the carrier results for haemoglobin S, C, D, E and O Arab. We inform the parents, we offer counselling and information, and offer parent testing. The second set of results that we receive are the newborn screen positive results, and those are for babies suspected of having a major disorder. So these are telephoned through from our Sheffield, our screening centre, straight to the team by phone so that we get the results quickly as possible. They'll then launch the newborn outcome system and we'll get an electronic referral. From there, usually the next step is I would just speak to our paediatric haematologist, because not all results are straightforward. Sometimes it's premature babies in neonatal units who've perhaps had blood spot done after a blood transfusion, or they're so premature they've not started making their hemoglobin A. So a quick discussion about the results, and then I'll inform the families, usually the same day. That initial results I'll give them by phone call. Hopefully I've had a relationship with them in the antenatal period, and we might have planned that phone call as a just in case. Where will you be? What shall we do? Who shall I ring? But not always, because some of our newborn screening results we haven't seen antenatally, so we don't know them. And then once I've given them the information in a telephone call, I'll then arrange a home visit. Often that can be sort of in the next sort of day or so they're not left with this information of, gosh, my baby's suspected of having a major condition, what does that mean? So during that home visit, we'll go through the results, what is sickle cell, what is thalassemia, talk about haemoglobin F, the fetal haemoglobin, and the usual haemoglobin A. I'll go through the genetic inheritance, quite often use the charts Joyce was showing us earlier on, and use pictures and things, because I think it's a really good way to share the information. I'll cover the first signs and symptoms of a major disorder, talking about treatment and longer-term health. I'll discuss the first clinic appointment and what will happen next, just to make sure the parents have as much information as they need. I try to offer reassurance. We're not expecting the baby to be sick straight away. They're protected by that baby's haemoglobin F, which they will have for the first few months. And I just encourage the family to enjoy their newborn baby. I'll give contact details for our team. I'll give them the Parents' Handbook, either from the UKTS for the thalassemia babies or from the Sickle Cell Society for the babies with sickle cell, or suspected of having sickle cell. Just to make sure they've sort of got some web addresses and things, so that after you've given that information, they're not going searching all over the world and getting different sorts of information, if they've got some reliable information. I try not to rush that appointment, and towards the end of the appointment, after they've answered any questions and things, we do mention future pregnancies at that point, and that they can get in contact with me and we can talk about future pregnancies when that comes round. The next bit of the pathway is that the children go to the first appointment in the paediatric clinic, and I usually attend that appointment as well to introduce them to the paediatric team, and that's where they'll have their confirmatory blood testing done, and if they are suspected of having sickle cell, then that's when they'll be started on their penicillin prophylaxis. And finally, just finish off with sort of discharge letters to the GP and health visitor, so everybody knows about the family and everybody can support the family. So the challenges faced, the first thing I've put is that first contact. If the family's not known to you, that first phone call you make is quite a blind phone call. You don't know where the person is when you make that phone call. You don't know who's at home and what information they know about these sorts of things beforehand. So it's always important to check where they are, because I've gone to give some results and they're in a car driving because they'll answer the phone, or doing a school run. So it's important to get the first phone call. That can be a challenge. Secondly, I've put when the family are new to the area or not known to you, perhaps they didn't have their pregnancy locally, so you didn't meet them during the antenatal screening period. This can include women with infants up to a year old who will have moved into the UK, because not all newborn screening is for newborns. Again, you have some babies that are 9-10 months old that have arrived recently in the UK. My next challenge group is the premature babies. Find this often very challenging, and we have quite a few come through, because often, I've learnt, premature babies are maybe at a point where they've not even started developing their hemoglobin A. So we'll get a result come through from the screening lab that says hemoglobin F only, or hemoglobin F and S or something. Therefore, they have to be suspected of having a screen positive result. And as I say, this could be just a carrier baby who's yet to produce the normal hemoglobin A. And this can be quite stressful, especially if one parent's a carrier and the other parent's not a carrier. And obviously that can cause additional stress during what is quite a stressful time anyway, with a sick newborn premature baby. Also, premature babies often have blood transfusions. Sometimes the blood screening, the blood spot, hasn't been done before their transfusion, and therefore that can complicate the results, because you need to wait at least 4 months post a blood transfusion to get an accurate hemoglobin electrophoresis. So sometimes that can involve genetic testing if the parents are anxious, and sometimes it's just a case of leaving the family to it. There's enough going on, and actually this is something that you pick up further down the line. I've put on here, not all testing is the same, and that's true. Not all testing is done to the sort of same UK accredited standards of hemoglobin electrophoresis by high-performance liquid chromatography, and that can be quite challenging when you've got a screen positive or baby suspected of being screen positive, and one of the parents has been previously tested, perhaps overseas, and is adamant they're not a carrier, and are questioning the testing that you've done, and also questioning paternity. And on that note, and I noticed Joyce picked up on it as well, I think it's important to say that not all private facility centres in the UK and overseas screen donors for hemoglobinopathies. So we've had pregnancies come through newborn screening, and we've actually then found, come through antenatal screening, and then had to do some testing as well for patients that have had IVF or surrogacy or something. Time constraints. We also have a group of women who come into the UK to deliver their babies and who plan to return home shortly after birth. Perhaps they've come to be with family or just to give birth in UK hospitals. Quite often they've got their return home plane ticket booked after delivery, and you've got this short time frame to organise some confirmatory testing and to see the paediatrician. The results can also be challenging because not all countries have access to the healthcare provision and things such as blood transfusions locally to where people live. And my last box is communication, and this is the biggie. Communication and cultural challenges. This could be something simple as sort of language, access to quality interpreters, resources in different language, visual aids, etc. But also, as Joyce touched on, the cultural aspects. A person's philosophy of health beliefs, it's not always a Western medical model that us in healthcare are used to or expecting. Quite often it can be more a culturally traditional philosophy, which can impact on people's understanding, particularly when you start talking about genetic inheritance and why people have sickle cell or thalassemia. So memorable experiences, quite often these are the scenarios that are talked about in the challenges, because it's those things that you remember. But one of my colleagues was once accused of wishing sickle cell disease on a couple's baby when she was talking about it. And again, it's really important that we have that understanding that people have different traditions and different beliefs, and respecting those, but also providing accurate information. We often face the situation that overseas testing has not proved reliable. We've had scenarios where children have been through newborn screening results have come back as a baby having hemoglobin SC disease or sickle beta thalassemia further down the line, and that the dad's adamant that he's AA from his screening beforehand, but actually he's hemoglobin C or he's a beta thalassemia carrier which hasn't been tested for. These situations can be really distressing for parents because particularly a lot of families, couples have had premarital counselling and testing done and are sort of expecting that they've reduced the chances for having a baby with a major disorder, and so this can become quite a shocking experience. And again, I've done here, this can't be my baby, I know I'm AA. So it can lead to more testing and a bit more time and counselling. We've also had couples who've had non-invasive pregnancy testing done at private clinics overseas, and even had samples sent to America for non-invasive testing, and trying to get across that actually this isn't something that yet is clinically available in hemoglobinopathies. It's still sort of in research and things, although perhaps with the stuff that's going on at Guy's and Thomas's it will become clinically available at some point. But this can be some of the memorable experiences. Of course, there's good stories as well, when it really goes well. And I can think of one family in particular where I'd got to know them antenatally. We'd had them through antenatal counselling. They'd made a decision not to have prenatal testing. The newborn screening results came through in in timely fashion so that we could actually get the results to the parents within 28 days to meet the standards. I gave them the results the same day. We arranged a home visit into paediatric clinic 2 weeks later. So lessons I've learned. I sound so old saying this. So going along as I've been doing this, it's really important to plan ahead. If I've seen them antenatally, that's great because I've got my background information, but I will plan in the antenatal period for when that telephone call, if that telephone call was going to come and we were going to give you some newborn results. Who wants to know? Does the mother want to find out? Sometimes the father says, tell me, and I will tell the mother. So it's getting an idea for how that will work beforehand. Picking the time of the interaction, I tend to go for later in the day when there is perhaps more likely to be more people around, both parents maybe. Also the office is quieter, and I wouldn't choose a Friday afternoon when there's no support available over the weekend. This is the one that comes from the ringing the lady who was in a car. Instead of saying, is it okay to speak, I actually ask them where they are, because then you've got the accurate information and they're not just driving along getting this information. Check who's at home for support and also for privacy and confidentiality, because you don't know when you're making that phone call. Who's in the room. Family can be there, and not all people want to talk to their family about these results straight away, so it's important to find out who's there. I always take visual aids. You'll see from my pretty slides that I like pictures, and I find that I've got a laminated A4 booklet that's of some PowerPoint slides just to share those visual, particularly like the inheritance and things like that. Always take information and leave contact details so the family feel that there's always somebody to ring and somewhere else to find reliable information. Again, I go through the genetic inheritance again because, and be mindful of the language used. It's not that the parents are passing on these genes, it's that baby's taking the genes and things like that, just to, because there are complications around guilt and things like that. And it does help when you know you have a relationship with the parents from the antenatal screening period, but if not, prepare, find out all you can. Some of my neonatal babies, I've had to ring screening teams in other counties and things to try and get some information, to try and get the parent screening results so that you've got some idea before you go in and meet them. So how can we improve experiences? So the first thing I've put is more accessible information, up-to-date resources in more diverse languages. Leicester is the UK's first plural city, and we're vastly proud of our diverse populations. But populations change, and it's important we develop resources in other languages to support the information to give to families from the newer populations. I've recently found myself more frequently needed Kurdish, Sorani and Pashto, as well well as the more traditional Gujarati, Hindi and Bengali languages. Healthcare professionals, education and training. The other thing I wanted to say was actually on the last one was that resources in different ways. So videos and videos filmed in different languages would be a useful resource to build so that you can share information. Because when you're using telephone interpreters a lot, sometimes you find yourself having to explain what a hemoglobinopathy is before you even start the conversation. And it can be quite challenging because you don't know how accurate the information that you're passing on is. Healthcare professionals keeping up to date with education and training, so the e-learning that we're going to hear about, the annual updates, the face-to-face networking, isn't it great to see people face-to-face, and the screening programme blogs that were a great source of relevant up-to-date information. Reducing inequalities and access to services. We're currently in Leicester working with our community public health team to raise awareness about haemoglobinopathies and early pregnancy booking. This is the team that worked hard during the COVID pandemic. I'm sure that's why you've heard of Leicester. But they were working to reach some of the hard-to-reach communities to make sure they had access to the vaccinations and health information. But we're using those teams to reach some, because these communities are similar communities that we're hoping to reach to give them information about booking earlier in pregnancy, because late booking has lots of implications all the way through the screening programme. The home visit I've got on there, I really think this is a valuable resource, ensuring that we don't lose that personal face-to-face home visit contact. It allows you to share visual information, look at non-verbal cues to enhance communication, and it's in a safe, relaxed environment. Parents can feel perhaps more able to be open and not rushed. Raising awareness to reduce stigma. This is massive, and this goes across haemoglobinopathies, but we provide general haemoglobinopathy carrier counselling, which enables people to have preconception choices and counselling. Celebrating the World National Awareness Days, using social media, attending community events, all build up sort of the public's knowledge and awareness of haemoglobinopathies, which will help with our families and the stigma they feel when you're giving newborn screening results about these conditions. I'm glad to know that's the last one. Okay, each time I deliver the screening results, it's different. Each family's got different circumstances, experiences, beliefs, understandings, needs and expectations, all of which influence how we give the screening results and how they're received. My role is to explain the newborn screening results, provide the accurate information about the haemoglobin disorder, and to listen to the parents. Listen at their pace, respecting their beliefs, and hopefully allaying some fears whilst they await their appointment and transfer into paediatric care.